The first one is by Jim Rimmer. Jim is director of the Lakeshore Foundation and is the Lakeshore Endowed Chair and Professor at University of Alabama at Birmingham. He does quite a number of things, but one of the ones that reflects his expertise is he's on the NIH Medical Rehabilitation Research Advisory Board. Jim will be talking about the nexus of rehabilitation and exercise, where and why the two should meet.
Okay, thank you, Jerry. Great pleasure to be here. I'll try to keep my presentation to 20 minutes. I have a tendency to run long, so I'll do the best I can. But it's a very exciting topic for me because most of my career was spent in physical education and exercise science, but I've kind of sort of crossed over now and spent a lot of time in the rehab science world. So these final stages of my career are really meant to try to bring the two together, and this presentation is sort of describing how to do that, or at least one possible approach for doing so. So the first thing to do is think about disability and what is a disability, and that's still something we battle with in the disability field. I came out of a Department of Disability and Human Development at the University of Illinois Chicago, where we had these interesting debates between the disability scholars and those on the rehabilitation academic side, addressing more of the impairment-related issues associated with disability. And those debates are good, you know, because they do get us to think about the breadth and the scope of what we mean by disability. I'm not too concerned about putting labels on people. I think that if we can look at this as what is the need of an exercise scientist in building a model that can help people transition out of rehab into wellness and health promotion, you know, I'm happy with calling it anything it wants to be called. As you probably know, many of you who are in the same profession I'm in, rehabilitation gets the corpus of funding, and it's not very much, by the way. I was part of a blueprint panel for NIH where they did a review of the amount of funding that NIH received for rehabilitation, and those numbers are very small with respect to what NHLBI got and cancer and other very important areas of science, but the numbers are very small, and that blueprint panel is publicly available. If you really want to read an eye-opener on how is disability defined, many of you may not be aware of the fact that there are over 40 definitions of disability that the government uses, from Medicare to Medicaid to Social Security, maternal and child health. You know, almost every bureau has some nuance of a definition. But the important issue is to put ourselves in a space where we can begin to think about how do we continue to promote and optimize the health of people as they either age with a disability or age into a disability. But either way, the convergence of these two lines and that Venn diagram with some of the demographics you'll see will start to get more space under each of those. So what does disability look like? And again, you know, coming from the field of disability, you see different pictures of people. The wheelchair sign now, you know, you've probably all seen the handicap parking sign. You know, that has changed. Now it's actually showing more movement. You know, the wheels are tilted to make it look like it's not this static position of a person. What we often hear about, people in our field like Jeff McCubbin and I, wheelchair bound or wheelchair confined, which are sort of disparaging terms for people because they're not bound to the wheelchair. They're not tied. They have the freedom to get out whenever they want. So just thought I'd show you a couple of pictures. This is from Lakeshore Foundation. They have a youth sports program. These two children don't even know what their disability is. One probably has spina bifida and the other one maybe mild CP, cerebral palsy. This is another picture from Lakeshore. Lakeshore is a Paralympic training site. It has two sanctions. One is it's a USOC site, so if an athlete in Alabama wants to train there, they can. But it's more of a Paralympic training site for three sports: goalball, wheelchair basketball, men and women, and what they call wheelchair rugby, which is what this game is all about on the bottom left. So this is a very intense game, and it changes a lot of attitudes when you bring undergraduate students over in kinesiology from Sanford College or UAB. They get really surprised to see how intense this game is, how much contact is as well. Military, there was a big bump in disability. You know, when we began the war in Iraq, a lot of head injuries, traumatic brain injuries, limb loss. This was a picture from when I was at the University of Illinois at Chicago, where we were working on a study in 2003 with predominantly African American women who at that time had just mobility disabilities. But if you look at this woman, her weight, you can see she has these bandages on her legs, these wraps. You know, there's a good chance she's probably going to lose a limb at some point associated with diabetes, maybe some of her vision, kidney failure. So again, you wouldn't classify her as having a disability. She's temporarily in that wheelchair. This is not something she used. You can see, doesn't even have sides on it. It was a photo op. No, I'm only kidding. We did ask her to get around in the chair because we were concerned about, you know, the issues associated with her weight. And then these are, you know, young adults with Down syndrome and intellectual disabilities participating in a karate class at the Rehab Institute of Chicago. So, and this gentleman is a picture that was taken out of the New York Times in May, front page, talking about the incidence of smoking in Kentucky. And you can see just by his face, you know, he's probably lost much of his fat, you know, could have other issues associated with substance abuse from what the story said. And he will certainly be one of the populations that we'll be addressing in the very near future, if not already. So disability demographics, it's an interesting group. When you look at the demographics, a lot of people, you know, they either think of kids with disabilities because they see the wheelchair and they go, oh my gosh, you know, everybody who has a disability must be a kid. They don't live to be older adults. But the demographics are quite different. You can see that we've got about one-third of the population over 65, 11% are 5 to 20, and 53% are in the working age population. When I talk about the perfect storm, I often look at people, and these are 3 pictures from our study in 2003 to 2006 at the University of Illinois, Chicago. There just seems a sense of hopelessness in people's eyes and expressions when they're in the hospital setting. You know, the medical care in our country is very good, and doctors and nurses do a fantastic job at saving a person's life. And once their life is saved, very often, you know, there's little else that you can do other than medication and good diagnostics. But doctors and nurses really don't have the time to talk about what we do, and certainly we feel in our profession that we should be part of this continuum of care. But yet, as you know, many health insurance companies will not fund or pay for the services associated with wellness or increased participation in physical activity. Now, this need will increase over time. This is the U.S. Census Bureau, but you can see the slope of the lines are really starting to pop right now in our current generation. These lines are becoming quite dramatic in terms of the number of people who are aging and are over 65, and those over 85, you'll see the jump occur after the year 2030. So that's another concern where if you're talking about one-third of the population currently has a disability and are over 65, that number will grow quite dramatically over the next 10 to 20 years. So what's life like after rehab? It's a lot of waiting in hospitals and clinics. You know, this gentleman had a stroke. It's a lot of sedentary behavior, a lot of sitting behavior. You know, the whole implications of science in our area really have had a difficult time breaking that barrier of continuing to support people. You know, this is an example where I think about, you know, what would it be like to speak to this gentleman in a health wellness setting where there are people exercising and enjoying life and giving people a sense of purpose or hope that no matter how severe the disability is, there's always that opportunity to increase your health in any way possible. What do people have with disabilities in common? Well, obesity is 2 to 4 times higher in this population. On average, they have 2 to 3 times higher rates of secondary health conditions. These are things like, we really haven't extrapolated what this means, but if you look at the data on secondary health conditions, and the major ones are pain, fatigue, obesity, and depression, these numbers are staggeringly higher in people who self-report as having a disability. And there have been a number of studies through CDC. Many of you might be aware of the Behavioral Risk Factor Surveillance System, where they track people over time, and they have found profoundly higher rates of 14, 15 different secondary health conditions: sleep, constipation, again, depression, obesity, anxiety. All of these are quite higher. And yet, you know, when I sit on study section, I don't see a lot of studies coming in looking at target groups of people with disabilities and addressing how do we address the issue of pain or fatigue, you know, in the broader population. You do see fatigue studies in people with cancer and other types of chronic conditions, but not in some of the populations that are disabled. Physical activity rates are generally lower in all age and disability groups, and access to employment, recreation, and social participation is extremely limited for many. So I've been trying to work through a model of how does this all look, and this is more of a policy presentation today than an exercise physiology one, because I often spend time with government officials. In fact, I received an email today from the Health, Education, and Labor program, which is directed by Senator Tom Harkin, asking for feedback on an inclusive fitness bill that they're currently working on, which is going to be Mr. Harkin's sort of swan song. You know, what should fitness centers look like? How do we build in insurance reimbursement for people to transition out of rehab into wellness? So I have to respond over the weekend to this bill to make sure that it has the appropriate language that's necessary to provide funding and services to the kind of things we do. So when I do that, I try to come up with models and hopefully have people who can help work with me on this. And generally what you see after an injury is you get a certain portion of rehab, and that number has gone down quite dramatically over the years. The length of stay now for some disabilities, like spinal cord injury, is about 22 to 25 days, which is really remarkable, because if you go back and look at the data 25 years ago, you got over 60 days of inpatient rehab, and now it's down to about 22. And just imagine going back to a rural part of southern Alabama 22 days after a car accident or a bike accident, learning how to get inside and outside your home, bladder and bowel maintenance, trying to figure out what you're going to do in terms of your insurance. You know, you've got probably tens of thousands of dollars of bills that have to be paid. People trying to figure that out. You may have to end up going on Medicaid. You lose your job. So there's a tremendous opportunity for us in exercise science to really fill that gap with these great students, hundreds, thousands of students who come out with an exercise science degree and don't have a modicum of knowledge in disability, which to me I cannot figure out how we can even begin to think about not offering more programs at the base of the pyramid where we get the highest number of barriers and the greatest health complications. So there's definitely a space for us to build and to grow into in this model for this reason and for others. Case number 2 is sometimes you do get a little bit of an improvement, and then over time, again, these secondary conditions take over the individual's life. They have to go back to work part-time, or they stop working, and depression sets in, or anxiety, or just apathy in general, and they start to see a slow decline, which is, you know, what I've been referred to as post-rehab health decline. So the question is, how can we begin to look at these disconnects between, you know, discharging a patient in rehab and they go home and they have nothing and they're not even sure where to begin? And again, I don't want to blame the healthcare industry, because they're overwhelmed as it is with seeing patients. But, you know, how do we begin to get our government officials to think about, you know, there is a gap here, and somebody's got to fill this space if you really want this continuum to reach people so you can lower healthcare utilization costs over time. If you look at the cost of healthcare for someone with a disability, I believe it's like a 4-to-1 ratio. You know, every $4 that we spend on healthcare goes towards the majority of people, you know, who have a disability. So the numbers are staggering. Some of those numbers we don't know if we can change, but certainly part of that funding, I believe we can, with sustainable community exercise. So there was a paper I published in 2012 that I'm trying to get out in the whole policy rehab arena, which is this thing called DALEADS, which stands for Disability Associated Low Energy Expenditure Deconditioning Syndrome. And in work that we did at the University of Illinois Chicago, this is in the late 90s, early 2000, you know, I just plotted the data points of people's peak VO2 levels that we measured. And as you can see from this one quick slide, all of the participants in different age groups, most of them had stroke, fell below the 10th percentile in terms of their cardiovascular health. So You know, we've got to begin to think about, you know, how deconditioned people are, how much are they sitting during the day, you know, and what are the risks associated with this behavior, partly due to the fact that the socio-cultural, environmental ecosystem sort of shuts down for an individual after acquiring a disability or being diagnosed with a disability. Parkinson's is an example, or Alzheimer's, presentation we heard this morning. You know, those are big conditions now that are growing again in the aging population. We're not quite sure what to do in terms of the optimization of health and wellness. So a model that I published a couple of years ago really kind of looks like how do we begin to build these closer synergies between rehab, transition, and community settings. And, you know, we already have some of these transitional settings. Many of us who were in the field of adaptive physical activity would set up these clinics on Friday night or Saturday, you know, and they were select for community members who had disabilities, and we'd get students to come in and work with the adults. And it was a, you know, a wonderful way to begin to introduce students, you know, in exercise physiology, exercise science, kinesiology, to disability. You know, things that sometimes they would be quite intimidated about, not sure they were able to handle it. But once they would go through an experience, they realized that they're just another individual on a continuum with certain limitations in function, but certainly, you know, this is not a dichotomous population. We say, well, disability is over here, and they go to rehab people, but I'm not a rehab specialist, so I don't work with people with disabilities. You know, it's all on the same spectrum. It's all related to health and function, and there's a great model out there that was published by the World Health Organization called the International Classification of Function and Disability in Health, where they kind of stripped out the disability, and they just look at, you know, disability is really the interaction between the individual and the person's environment. And the environment has a greater weighting in the formula in terms of the potential opportunities or limitations that one might experience in their own community. The other part of this is at Lakeshore Foundation, I was, you know, to get somebody with a very thick New York accent to live in Alabama for any portion of time had to draw me there for a reason. So the reason was Lakeshore Foundation, which is a large 100,000 square foot facility on a beautiful campus, actually said, you know, we really want to build this enterprise of building the connection between rehab and exercise. And on the campus of Lakeshore is Health South. Some of you may have heard of Health South. They have 103 facilities. They discharge 130 patients a year. So if anybody wants to do research on stroke or Parkinson's or other issues, we have direct access. They're actually landlords on this campus to the foundation that I work for. They pay rent to Lakeshore Foundation to be able to host their facility on the campus. There's also cottages that I'll show you. So I'm opening this opportunity up for us as colleagues, because we're really in the same family, and we really need to begin to think about this in terms of how do we build a model that will work for exercise physiology. So this is kind of the model where, you know, you have to look at that crossroad. What can we do once rehab ends in order to keep people active? There are a couple of new programs that have come out over the last couple of years. Beyond Therapy has a program that's doing this. Brooks Rehab in Jacksonville, Florida. And, of course, we're doing it at Lakeshore Foundation. And I'm not going to have time to go through this, but it's a model that I've been looking at, which has a couple of different things going. You come from rehab, then you go into some kind of function. You have these domains of who would be treating you, the timeline, the setting, and what systems you're working on. So, for example, if you're in this section here, then you're working with a colleague that I have, David Brown, who I know Dan knows, and he has a machine. He works specifically on one system to try to build an individual's capability of preventing falls in the future after stroke. I also work with Ed Taub, who's kind of the world-renowned constraint-induced therapy guru, and Ed focuses, you know, a lot of his work on constraint-induced therapy, which works one system or one limb. Again, this is not written in stone, but it's trying to map out, you know, this transition from restoration to transformation to preservation. Because a lot of times what you'll see people do when they come through our program, as soon as they get well or they feel better, they stop, and you never see them again. And it's just like a revolving door. You know, we've got over 2,500 members with disabilities and chronic health conditions, but a lot of them don't come to the gym. So another spot that we need to look at is the whole issue of adherence. So let me just end this quickly, because I know we're running out of time, and these are my last two. How can we get funders to financially support the gap? Is there a need for PT and OT to develop standards for optimization of recovery in community-based facilities? How can we get the American College of Sports Medicine and the American Congress of Rehabilitation Medicine and the American Physical Therapy Association to work more closely and ensure embedded training for exercise science students, embedded transitions from hospital community? And how do we reach geographically and isolated populations, which is such a critical area and void, and something that we need to consider? This is just another model that I've been working on for a future grant, and it talks about this T3 or T-cube model, which you try to take a person from therapist to telecoach to trainer. And one of the future growth areas at Lakeshore is to build a large telehealth, tele-exercise facility to be able to coach people remotely in geographically isolated communities. The technology has gotten to a point now where we can monitor heart rate and blood pressure remotely with systems that people wear, and you can coach them in real time. Bit of a challenge to get through the IRB, but we did get this one study approved, and we're planning to start that this fall. And the challenge ahead of us is we've got to get third-party payers and federal insurance programs to respect and appreciate the potential we have to reduce healthcare utilization costs among more than 50 million people with disabilities. We need to build support for the notion of transitional settings that are funded. We need to encourage university exercise science programs to include more disability-related content. And we need to incentivize the fitness industry to obtain ACSM certification, the Certified Inclusive Fitness Trainer, which is an entry-level degree, and the Registered Clinical Exercise Physiologist. A couple of pictures of Lakeshore. We do have facilities on campus for housing. We can keep people there as long as we want. Everything is completely universal design. That's the entranceway to the 100,000 square foot facility. And then you can see we have cottages. We have space for probably 50 to 60 people to be on campus for any length of time for future studies. And this is just a new model I put together for the owner of Lakeshore Foundation, or the architect, thinking about, if we had to hit a sweet spot, where would it be? And for me, it's exercise, mindfulness, and nutrition. As you know, many of the programs today, departments have combined exercise and nutrition, but I also think this is an extremely important part of synergizing what we do so well in exercise and diet to get a more, to get a greater effect. These are all hypotheses that could be tested, but I really do believe that in some cases when a person has an injury, you have to really get to their mind first before you can even get them to think about, engaging in wellness or health. And then there are 3 spots on the inside here: food quality, diet, behavior, mind, body, spirituality, and staying in the now, fitness, aquatics, recreation. And then 3 target areas, and these can change for anyone, is obesity, depression, deconditioning. So in conclusion, I'd like to share anything that we have available to you, to me, to you. We do have resources down there that, when I went down there, they put $10 million on the table to do research in physical activity and disability. It was a hard sell, but I told them if I can get colleagues like you involved in the research we do, either residentially or things you want to look at cross-sectionally, we definitely have the population and the staffing to make this go. And of course, my ultimate goal is to improve the lives of people with disabilities, and I need you to be able to help me do that. Thank you.